Welcome to this episode of Psoriasis Uncovered, a podcast series produced by the National Psoriasis Foundation, the nation's leading organization for individuals living with psoriasis and psoriatic arthritis. Join us to hear our guest speakers uncover topics that lead to a better understanding of the disease and management, to coping and thriving with psoriasis and psoriatic arthritis.
My name is Archie Franklin. I'll be your moderator for today's discussion about the latest news surrounding the use of incretin hormones like GLP-1 receptor agonists, metabolic disease, and management of psoriasis and psoriatic arthritis. Joining me is leading dermatologist and the vice chair of the NPF Medical Board, Dr. Ronald Prussick, who is the medical director of Washington Dermatology Center in Rockville and Frederick, Maryland. Dr. Prussick is also a clinical associate professor in dermatology at George Washington University in Washington, D.C. Also here is Dr. Brittany Weber, cardio-immunologist, who is the director of the Cardio-Rheumatology, Cardio-Dermatology Program at the University of Texas Southwestern, where she is also a member of the Division of Cardiology, a clinical investigator, and imaging specialist. Welcome, Dr. Prussick and Dr. Weber. It's a pleasure having you here to discuss the latest research around incretin hormones like GLP-1, receptor agonists, and metabolic disease in relation to psoriasis and psoriatic arthritis. Dr. Prussick, let's start with a broad discussion about incretin hormones like GLP-1 receptor agonists. There seems to be more of this type of medication released every year. In fact, orforglipron was just approved by the FDA on April 1st. And we really like to know, what are incretin hormones and what does GLP-1 receptor agonists or GIP RA stand for, and how do they work in the body to regulate appetite and initiate weight loss?
Well, thank you very much for having me. And what hormones are, they're produced by specialized cells in the small bowel after nutrient ingestion. So they work by lowering blood sugar, by stimulating insulin production, and they inhibit glucagon. And what this does is it slows the stomach from emptying, so the stomach feels fuller, and that's why you don't have as much need or feeling that you need to eat because your stomach feels full. It also affects the receptors on the brain to also make you feel fuller quicker after you eat. So what GLP-1 stands for, it's called glucagon-like peptide 1 receptor agonist, and GIP stands for glucose-dependent insulinotropic polypeptide agonist. So basically, these are just the two most important incretin hormones that are produced by the small bowel from specialized cells from the gut. And these drugs are approved. They were approved initially for treating diabetes, and then at higher doses, they're treated for weight management. And they are available through subcutaneous injections, and now there are 2 oral versions.
That's great that there's options for patients. I think it's very important to have options like we do in both oral and injection. Just amazing how this hormone in the gut can have such an impact. Why are incretin hormones like GLP-1 receptor agonists of interest in the management of psoriasis and psoriatic arthritis?
Well, we know that obesity drives the psoriasis. We know that patients who are already overweight or obese have a higher risk of developing psoriasis and psoriatic arthritis if they have the genetic susceptibility. So by tackling the obesity, that will reduce the inflammation in the body. So if you think about fat cells, the fat cells that are in the stomach area, the center part of the body, are different from the fat cells in the arms and legs. They're metabolically active and they produce a lot of the inflammatory cytokines that trigger psoriasis and psoriatic arthritis. So that's why the obesity is so important, and that's why people who have obesity are at a higher risk of developing psoriasis and psoriatic arthritis. And we know that patients with obesity have more of these inflammatory cytokines because they have more of these specialized fat cells that are in the center of the body. So that's why we're really focusing on reducing the obesity, reducing the fat cells, reducing the source of inflammation, because psoriasis isn't just a skin and joint disease, it becomes a systemic inflammatory disease with a lot of comorbidities and a lot of health risks, including the risk to the heart and the liver, etc. So we're trying to prevent all that by reducing the obesity.
Certainly, we've been talking about comorbidity for years, and this is wonderful news that we have some products that actually help that systemically. Which brings us to Dr. Weber. Hearing this connection between GLP-1, psoriasis, psoriatic arthritis, what's the connection with metabolic and cardiovascular disease and the immune cascade associated with psoriatic disease?
Yeah, thank you so much for this question. And what an excellent topic that we're getting to discuss today. So, first, I will say that psoriatic disease exists within a complex network of systemic inflammation. It's really where it's the confluence of the conditions: skin inflammation, metabolic dysfunction, and cardiovascular disease. We now know these are interconnected through shared inflammatory pathways rather than just simply co occurring together. We know that the chronic inflammation in psoriasis involves many of the same pro inflammatory cytokines. These include things like TNF alpha, IL-6, IL-17, that also drive insulin resistance and atherosclerosis, and cytokines that we think about from the cardiology angle itself. And so, what does this create? It creates what I describe to patients as this vicious cycle where inflammation really is promoting the metabolic dysfunction, and that's perpetuating more inflammation in this kind of ongoing feedback loop. We also know, as just mentioned earlier, that metabolic syndrome is really common in our patients with psoriatic disease. This is substantiated in large data sets where the prevalence is much higher compared with the controls, with increasing proportions to how severe the psoriasis itself is. And so we know the adipose tissue itself plays a central role. It's a kind of an active immune organ that I'd like to describe to my patients. It secretes its own inflammatory adipokines. It creates this abnormal profile. And this shared inflammatory biology really explains why targeting these pathways, whether it's through the traditional biologics or emerging therapies like the GLP-1 receptor agonists, can potentially address both the skin and the cardiometabolic complications together.
Again, great news for patients like me, and we're always looking forward to new and better treatments. One of the most frequent conversations I have with my fellow psoriasis patients is this comorbidity issue. And you mentioned some of the larger studies. Research from Dr. Joel Gelfand and Dr. Nehal Mehta has shown people with psoriatic disease are at a higher risk for cardiovascular disease. Is it possible reducing inflammation through the use of systemic treatments and GLP-1 receptor agonists will impact cardiovascular risk?
This is such a great question and also a big one. So first, I will say that we know that the cardiovascular impact on our psoriasis patients is substantial. The statistics can be alarming to patients. Severe psoriasis can carry upwards of a 70% increased risk of having a heart attack, 56% risk of having a stroke, and overall 39% increased cardiac mortality, even after accounting for those traditional risk factors. So it's very important that we don't negate the importance of treating the traditional risk factors, but psoriasis itself is inherently high risk. And why is that important? Well, it's important because our guidelines we utilize in cardiology recognize the limitations by which our risk calculators assess risk. And so psoriasis is labeled in the guidelines, including the most recent updated guidelines that came out within the last month, the PREVENT guidelines and the new dyslipidemia guidelines of psoriasis as a cardiovascular risk enhancer. So going to your question, it's clear, as I just mentioned earlier, that reducing inflammation through treatments like GLP-1 receptor agonists appears to reduce cardiac risk. And then we can talk about biologics. Certainly, when we talk about some of the studies you were mentioning, the evidence is stronger for some therapies than others. However, what we're learning is that they're complementary mechanisms, biologic targeting disease-specific inflammation and GLP-1 receptor agonists through both the metabolic improvement and some direct inflammatory effects. And so if you just look at these studies a little more in depth, there's really been multiple observational studies demonstrating that biologics reduce cardiovascular events compared to topical therapy and methotrexate and psoriasis points. There's also been population-based studies that have showed similar effects. I will say I don't think we have the granularity to say whether one specific biologic, an IL-23 or compared to an IL-17, is more beneficial in this question, although I do feel confident when I tell my patients that treating their psoriasis with appropriate biological therapy will reduce their risk. And then speaking along to the GLP-1 receptor agonist, the cardiovascular evidence is really robust. If you just look at meta-analysis, which there's been many in cardiology, we can observe that these agents reduce major cardiovascular events by 12 to 14%, cardiovascular death by 12 to 13%, stroke and heart failure hospitalizations among people with diabetes. And then we have the landmark trial in patients without diabetes. So that's why when we're discussing these topics for our patients with psoriasis, I would say that how I think about approaching GLP-1s in a patient with psoriatic disease, having psoriasis and obesity, it's not that you automatically mandate these therapies for reducing their psoriasis therapy, but it certainly creates a compelling rationale for consideration.
Certainly so. And as someone who's had psoriasis for over 40 years, I'm feeling somewhat guilty that I haven't seen a cardiologist since my disease. But
no, well,
I will
we have to change that. And I certainly
yes.
will say that we're really excited as a plug that I'm down here at UT Southwestern, just recently moving from Brigham and Women's. And it's an exciting time because we've established the very first cardio-dermatology program. And so I'm really hoping that we can advocate for more programs like this across the United States.
Well, thank you so much, Dr. Weber. Dr. Prussick, back to you. What treatment challenges do you typically see in people with psoriatic disease who are overweight or obese? And when would you consider prescribing a GLP-1 in combination with diet and exercise?
Well, this is an important question because obesity will significantly affect treatment response. What we know is that patients who have obesity have about a 30% reduced chance of achieving a PASI 90 response. So the treatment response won't be as good, and therefore we often have to try something, and then it doesn't work, then we have to switch to something else, then switch to something else. So I think that we see more switching and poorer response due to high BMIs because there's more systemic inflammation. There's more comorbidities. There's increased depression and there's increased cardiometabolic disease. There's also been some studies that show when you look at the UK general practice database over a 16-year period, when psoriasis patient gained weight, so they went from a BMI from, let's say, 25 to 30, there was a 13% increased chance of eventually developing psoriatic arthritis. And the opposite happens when they lost weight. When they went from a BMI of 30 to 25, they had a 13% reduced chance of developing psoriatic arthritis. So obesity will increase the risk of developing psoriatic arthritis as well.
I can remember when I was in one of the clinical studies for a biologic, they had two different doses, and I had to take the higher doses because I was heavier. So very interesting that that's been around, I guess, and we understand that.
It's good you brought that up because over the years, we've had a couple of drugs that are actually weight-based dosing, one called infliximab, the other was ustekinumab. But unfortunately, most of the other drugs are not weight-based dose. So if you think about it, you're giving the exact same dose for someone who weighs 150 pounds and someone who weighs 300 pounds. And so, of course, you're relatively underdosing the people who are heavier.
And could that cause why sometimes many of my fellow psoriasis patients had to switch biologics?
Yeah, because they're getting a lower dose relatively, and also the fact that they have more systemic inflammation. Because when we talked about that belly fat, you're getting higher levels of systemic inflammatory cytokines, so it's harder to bring them down when you have more.
Very interesting. And certainly I really appreciate and thank you for addressing the impact associated with systemic inflammation and the use of GLP-1s or GIP medications. Such issues and more recently addressed in the NPF position statement, GLP-1 receptor agonist in psoriasis, a primer from the National Psoriasis Foundation Medical Board, of which you are both authors. Can you please each speak to the key points around the use of GLP-1 receptor agonists when managing psoriasis and psoriatic arthritis, as well as the new field of cardio-dermatology? So we can start with you, Dr. Prussick.
Well, from my point of view, the main point is that psoriasis and psoriatic arthritis shares similar inflammatory pathways to obesity. And so I think it makes sense to reduce the obesity by any means you can, including using GLP-1 receptor agonists. So You have to realize that the GLP-1 drugs improve many of the comorbidities associated with psoriasis as well by patients losing weight.
And Dr. Weber?
Yeah, thank you so much. And such a pleasure to be a part of what I hope to be a very useful document for the community. And so I think a few key points I would like to mention is that number one, we need to be thinking about obesity as a disease modifier that can impair our treatment response, as we just heard earlier by Dr. Prussick. We need to think about weight loss, improving psoriasis outcomes, as already mentioned. The point that GLP-1 receptor agonists can offer dual metabolic and disease modifying benefits, and the data is just increasing. I would say I've got even more excited by the very recent results of the TOGETHER Psoriatic Arthritis trial that demonstrated a really dramatic improvement in risk reduction in psoriatic arthritis endpoints when you combined tirzepatide with ixekizumab. So basically, if you combine both biologic with GLP-1 receptor therapy as an additive benefit. And then I think two other important points that I would like to emphasize that I hope you would appreciate in this article is really practical considerations when you do prescribe them. So we should remember what they're currently FDA approved for. I prescribe these in my clinic, so it's very important that you know this because we certainly still have issues with approval rates, but they are approved for type 2 diabetes, obesity, that would be a BMI greater than 30 or 27 with a comorbidity, cardiovascular risk reduction, as already mentioned by the SELECT trial, and then the metabolic steatohepatitis. It's not currently an FDA labeled indication for psoriasis itself. And so you should be considering these therapies when they have these conditions, as we just talked about. Key barriers, though, as I just alluded to, would be insurance coverage and cost, GI side effects, which we didn't have the time to get today, but the article will go through, and also coordination with the multidisciplinary nature. And this is really where I'm excited for the emerging field of cardio-dermatology. And then my very last comment would be that these should complement, not replace our other therapeutics. And so I talk about this a lot in terms of when I'm thinking about my cardiovascular risk reduction agents as the synergistic benefits. So, I'm going to treat your cardiometabolic risk factors, and we're also going to be working with your dermatologist to treat your psoriasis. And so I think that's a key point that I hope that comes across in the article as well.
Dr. Prussick, given this, it makes sense to combine a biologic that also utilizes IL-17 and a GIP, GLP-1 receptor agonist therapy, which is exactly what occurred with the TOGETHER-Pso and TOGETHER-PsA phase 3 clinical trials. Can you please share results from these trials, which were presented at the American Academy of Dermatology's annual meeting in March?
Sure. These phase 3 clinical trials, and in both trials, there was a combination of an interleukin 17 inhibitor for psoriasis called izokizumab with a GLP-1 receptor agonist called tirzepatide. So the patients needed to have a BMI greater than 30 or a BMI greater than 27 with at least one weight-related comorbidity to enter the trial. So there were these two groups. One was the interleukin 17 inhibitor psoriasis medicine alone versus the interleukin 17 psoriasis medicine with the GLP-1 agonist together. And the results in the psoriasis trial at 36 weeks, that the combination, 41% got a PASI 100, means they had completely clear skin, versus only 29% if they were just taking the psoriasis biologic alone. And 27% of them got both perfect skin and at least a 10% weight loss if they took both. In the psoriatic arthritis trials, the combination of both drugs, 33% got an ACR of 50 versus only 20% when they took the psoriasis interleukin 17 inhibitor alone. So 32% of patients achieved the ACR 50 and at least a 10% weight reduction in the psoriatic arthritis trials if they took both, versus only 0.8% if they took only the psoriasis biologic.
Dr. Prussick and Dr. Weber, how do you approach the addition of a GLP-1 medication with your patient's treatment regimen? What's that conversation look like?
Well, I would say you have to be sensitive, because when people come to a dermatologist, they're not expecting me to talk about their being overweight or being obese. They're expecting me to focus on their skin. So often I'm the first one to tell them that being overweight or their obesity can impact their disease, just so that they know about it. But usually the first visit, I'll really focus more on the skin and just mention it And we'll talk about the diet and lifestyle on follow-up visits. And that way they know it's coming. That's how I approach it rather than talking about their obesity on the first visit. I find that patients like it better when I deal with the skin. And then as they get better with all the great drugs we have, I can focus on their diet and lifestyle. I talk about the Mediterranean diet and about avoiding high glycemic index foods. And also we'll talk about the GLP-1 agonist if diet and lifestyle, they cannot lose weight. And I tell them that it's really important because that weight gain that they have over time can produce psoriatic arthritis over time, and the disease can become a cardiometabolic disease involving not just the skin and the joints, but their whole body and resulting in systemic inflammation. And patients can have heart attacks, strokes, and even live less than the general population. So they take it seriously after I review all that with them.
I would agree with your approach, Dr. Prussick. And I really liked what you said first is it's a sensitive topic, right? I live in this really exciting space of cardio-dermatology with my clinic where I get to see people with inflammatory disorders. But as their cardiologist, I'm focused on cardiovascular risk reduction. And so I think it's really important that we set the tone right for our patients, right? So I basically say we have these new cardiometabolic treatments. I don't say the word weight loss, right? I don't want to stigmatize it. And I describe how that may be relevant for their psoriasis itself. So I kind of say like three things up front. I tell them why they qualify and that by your weight, you qualify. And I'll say, we now know the role of obesity in driving. And I go through that. And of course, if it's diabetes, it's a different conversation, a little bit easier to have that conversation because usually they've heard of these drugs in terms of diabetes, not always though. And of course, in established CBD. And then I kind of tell them, what does success look like for me getting them on these treatments? And I think this is a really important point because in cardiology, if we look at our landmark trials, you can't explain the benefit solely on weight loss. So if you look at the way the curves kind of separated in these trials, obviously we know the benefits of weight loss reduction, but there's benefits of these drugs beyond. So people who are on these therapies who don't get as much weight loss as they're hoping for, they still get benefit. And so I really make sure patients hear that from me, like you are deriving benefit from these therapies. And I really tell them the wide array, right? Because more and more studies are coming out across fields, right? Sleep, OSA, we already have heart failure outcomes data for heart failure with preserved ejection fraction, right? So a specific phenotype. And so there's so many ways that these are helping patients beyond maybe a number in their head they're trying to achieve. So I talk about all those. And then I basically say that this is an area of emerging in this field where we're continuing to learn ways that these drugs may actually even benefit their psoriasis itself.
I want to thank both Dr. Weber and Dr. Prussick for our discussion today. Do you have any final comments you'd like to share with our listeners?
Yeah, thank you very much. And I want to just leave us with it. Such an exciting time to be at this intersection of cardiology, dermatology, and rheumatology. And if I could leave the listeners here with one key takeaway, it's this. We have to stop thinking about psoriatic disease and cardiometabolic disease as separate problems requiring separate solutions. Hence, my passion of the field of cardio-dermatology. I hope that you understood through this podcast the inflammatory pathways that drive psoriasis are the same ones that accelerate atherosclerosis, insulin resistance, and fatty liver disease. We've talked a lot about how GLP-1 receptor agonists can represent really a future of a paradigm shift here because they address all these multiple nodes and how they can work together. And so for patients listening, I want to really encourage you to don't be afraid to bring this conversation to whichever clinician that you're seeing, whether it be your dermatologist, rheumatologist, or your cardiologist. And what I believe so passionately about and that I want to really leave home with is the best outcomes are really going to come from multidisciplinary collaboration. And the evidence is now strong enough that these discussions should be happening at every visit. And so we're really only at the beginning, and I'm really looking forward to all the future. So thank you again.
Thank you, Dr. Weber. Dr. Prussick?
Yeah, I would just summarize by making sure patients need to understand that their increased weight does impact their disease and increase their risk of having more severe disease that's harder to treat, and they may develop more comorbidities and psoriatic arthritis. If they can't lose weight with diet and exercise, consider going on one of these GLP-1 agonists to see whether or not they can help them lose the weight. And just try to do your best to communicate that with your physician, that you're aware that the weight is a problem and you're not able to do it through diet and exercise alone, and see how that goes.
Thank you very much. Dr. Weber and Dr. Prussick for your comments discussing the use of incretin hormones like GLP-1 RAs and GIP RAs with psoriasis and psoriatic arthritis. It will be interesting to see how the knowledge and work progresses to have better understanding of managing weight and psoriatic disease. If you would like more information about incretin hormones like GLP-1 receptor agonists and tips for managing your weight, visit our Total Body Wellness Resource Center at www.psoriasis.org/total-body-wellness/. Our sincere thank you to Lily, who provided support on behalf of this program activity. And finally, thank you for listening to Psoriasis Uncovered, where we uncover what you need to know about psoriasis and psoriatic arthritis.
We hope you enjoyed this episode of Psoriasis Uncovered for people living with psoriasis and psoriatic arthritis. If you or someone you love has ever struggled with psoriatic disease, our hope is that through our podcast, you'll gain information that inspires you to lead a healthy life and look to the future. Please share the episode link if the content in today's episode will benefit someone you know. You can find this or all future episodes of Psoriasis Uncovered on Apple Podcast, Spotify, Amazon Music, Ghana, Pandora, iHeartRadio, and the National Psoriasis Foundation webpage. To learn more about this topic or others, please visit psoriasis.org or contact us with your questions or comments by email at podcast@psoriasis.org.